We are back on Morning Line. Thanks for joining us. Our guest, of course, is Clint Kelly, Malpractice attorney. The phone line's open, 737-7587, if you have a question or comment from him. And it's interesting. Every once in a while, Clint and I will talk, and I'll learn something more disturbing about why you need to be aware of what's going on in hospitals and the staffing issue of all this. We talked earlier about nurse involved in a case, a couple nurses involved in cases, some of them working at facilities now, and they don't necessarily all, not just nurses, but the staff in general, don't always just work for that facility, right?
That's correct.
So this is a relatively new thing where they're adding a middleman, if you will. Explain how that works.
That's correct. We are used to thinking that the people who work in the hospitals are hospital employees, or the people who are working in clinics or assisted living facilities are the employees of the facility. Wrong.
Right.
Wrong for a number of reasons, but primarily because more and more hospitals and facilities and even clinics are hiring staffing companies to fill these facilities with workers.
Okay.
All right, so let's say, for example, you need nurses to provide assisted living care to people with Alzheimer's. All right, you go hire, just say, Farmington Staffing Agency, and Farmington will produce nurses who have experience dealing with people who have dementia. And so Farmington will be responsible for hiring, interviewing, hiring, training, basically putting somebody ready to go from day one.
And these hospitals have to trust that what they're getting, because they're not doing any vetting. They may vet the agency they're hiring to see do they have a good reputation, but those people coming in,
you are correct.
Cold.
You're correct. Now there will be an orientation, obviously, to try to get the new employees, acclimated to the new environment. But you're right, all of the trust is on the staffing agency to get everything on the front end correct. But what I was telling you off air is I think one of the main reasons for this is the hospitals and these healthcare facilities are putting down an extra layer of protection, or let's just say an extra layer of distance between themselves and their employees, so when acts of negligence occur on the premises, it's harder for the patients to sue the hospital.
Yeah, it's the staffing agency.
Yeah, because the hospital says it wasn't our employee, it was Farmington Staffing Company's employee. We just supply the premises.
That's exactly what's going on. That's exactly it. Now, that doesn't mean you can't sue the hospital, but it's an extra layer and does provide them maybe some protection where ultimately a jury says, well, hospital trusted and this is a registered agency that they could get from. It's the agency that has to be held accountable.
Yeah, but it does make it tougher on the patient, because the patient's like, look, how am I supposed to know Nurse Richmond here was not your employee when she's, giving me shots and giving me medicines and all kind of stuff? And hospital says, well, didn't you read that contract you signed when you came in, which says that all of our staff are independent contractors?
Yeah. It's not just nurses. Weren't we talking about this a while back, where now in some of the hospitals, you're in the room and they're wheeling a TV monitor in. And what they're popping up is a closed circuit affiliate channel where you're talking to a doctor at a hospital maybe across the country who has been told, and you're seeing them on a video screen in your room, but they have never come and touched you physically, and they are at another hospital, maybe across, and what are they, contracted, or are they maybe part of the same hospital chain, and they're tasked with supervising you halfway across the country.
Yeah, it's telemedicine, and very specifically it's a teleconsultation.
I've been meaning, I need to do a story on this, because that's done to me. Now, I haven't had that happen to me yet, but if I'm in a hospital room and someone's wheeling in a TV set and all of a sudden the doctor pops up and he or she's talking to me and diagnosing and telling me, and they're not even at the hospital, I have a concern with that.
Well, ask yourself a question. Okay. If you're running a business, and that's what hospitals are, even the nonprofits, they're trying to make money to pay all the staff.
Right.
They have to spend all the money they make. If you want to reduce the number of medical staff, particularly high-end staff, but maintain the same number of patients, okay, which obviously enhances your bottom line, how do you get that doctor to more patients? Because obviously if you go from 10 to 5, you've got twice the number of patients each doctor has to see. How do you make it easier for that doctor to see more patients? Particularly if those patients are in another part of the state.
Right.
Put them on TV.
Okay, and what's the problem with being on TV? I mean, some people might say, look, doctor's been briefed. He can look at you, because I assume maybe the doctor has a reverse camera where he can see you. I don't know, maybe not. Why don't you think that's a good idea? And that's kind of a stupid question because I can tell you exactly why it's not, but go ahead.
Well, you tell me. Why do you think?
Well, because the doctor's not there with you. There's certain things you can pick up when you're face-to-face with an individual. When you can address it, you can see them in the flesh. I mean, to me...
Radiologists don't see people in the flesh sometimes. Sometimes they just look at scans and
I
that's
guess
it.
maybe it depends on the condition you're being treated for. That's true. Okay, so maybe there's certain doctors I'd be more comfortable dealing with that with than others. But there's certainly some that I want them to physically take a look and maybe wiggle my knee if I think the ACL's torn instead of being told it and
Here's
looked at it.
my thoughts on it.
Okay.
Maybe my thoughts are more economical. I don't have a problem at a visceral level with someone providing a consultation by television if it's appropriate under the circumstances and the information can be provided and a diagnosis.
Okay, so it depends on the case. Okay.
It depends.
Okay, all right.
Here's what bothers me. If they're going to do that, I would expect that to be a reduction in my hospital bill or a reduction in my consultation fee, so my bill would be less.
Your argument would be why? They'd say, well, look, if there was a real doctor here, he or she would be doing the same thing.
Charging me more.
Yeah. Well,
Okay.
maybe, but I'm just saying we're charging you more because we're charging you the same price whether they're on TV or in person because you're getting the same information.
Exactly. When that's not the case is the provider or the hospital or both, they're saving money by doing this by television because the doctor doesn't have to go somewhere else.
Oh.
He can see more patients.
So they should give you a discount maybe because they're saving
But
money.
the discount's not going to go to me.
Of course
it's going
not.
to go to the doctor and the hospital.
That's why
Do
they're
you see
doing
what I'm
it.
talking about?
Yeah.
That's why our healthcare prices continue to rise. There's no competition. There's no pressure on any of them to hold those prices down.
Right. And when they can do something like that to save money, it just enriches them.
If you saw in a commercial, Vanderbilt did this type of service and your bill was going to be 20% less versus Centennial, which does the same thing and there is no reduction in price, would you go to Vanderbilt or would you go to Centennial?
Right.
I don't know. Some people may go to Centennial just because they feel like it's a better hospital. Others may say, God, my bill's going to be 20% cheaper. I go there. The problem is we don't know what our bill's going to be, do we?
No, and that's the other point. I always like asking you this. Should you ask when you go in? The thing is, okay, I've got an insurance policy here, and I'm a relatively healthy person, so I have a high deductible. So oftentimes I pay, they say, well, we'll get your insurance. I go, okay, fine, get it. But guess what? I'm paying right now with my HCA account because I've got a deductible. I'm not close to it. So I find myself now, because I'm like this, and I didn't used to do this when I had insurance with a low deductible, I'm asking, how much is that CT? I had to have a CT scan a few weeks ago because they thought I had a bad sinus infection. And I'm like, how much is that CT scan? I want to know. And it was about $400. And I was thinking, could I shop around? Sure I could, I suppose. Now the CT scan office was right across the hall from my allergist's office, so I thought, okay, I'll do this. But that got me thinking, what do you think? Is there anything bad? I'm finding out how much it costs. In the past, I never would have asked how much that CT. Now I'm asking, how much is this shot I'm getting in my butt right now for cortisone? How much is that? I want to know. And trust me, when they tell you, you're like, how much? What? Or, some places are cheaper than others.
My experience is they're very poor at being able to give you an estimate of what it's going to be because there are a lot of factors that are difficult, at least on their end, to put together into one bill. Like they can give you us getting our car fixed in a crash, we can go to a body shop and we get a quote of what it's going to cost.
Yeah.
You go and ask a hospital for a quote of what it's going to cost to take care of you, they can give you a range, but the range is really
But when
really
you're having a
large.
procedure or just an office visit, I think it's fair to ask. That's another thing. How often do you ask what your office visit? I'm coming in just basically to meet with an allergist to see if I have a sinus infection. They're in there with you for maybe 20 minutes, 15 minutes. How much is that office visit going to cost me? And those
know
basic
that.
things, and I ask all the
Or
time
what a
now.
colonoscopy costs. They can tell you that.
I'm asking on that, even though those are covered by my insurance.
And that's fine. I'm talking about things I think that are more substantial that can really hurt you, which is you go to a hospital for a 5-day, let's say you got to go in and have like a AAA, aortic aneurysm operated on time, and you're going to be in the hospital for 5 or 6 days because of this new procedure. It's a thoracic aortic aneurysmal repair that's done on the inside of the body laparoscopically. You can be out of the hospital in 5 days. You ask them, what's that going to cost? They cannot give you a reasonable range. They don't want to.
They won't tell you because you may have a heart attack there on the spot. It's just, I'll tell you, the prices, asking and comparing, some people, if you have the time, it's not an emergency, you can do that. Let's take a call from Joe. Joe, good morning.
How's Joe?
Hi, Joe.
Good morning, Nick. I got a little scenario for Mr. Kelly here.
Okay.
See what he thought of it. Went to the emergency room. I had my leg was swelled up and giving me trouble. And the first thing that happened, there was a young man with the nurse in the little room they put me in, and he was going to EMT school, learning to be an EMT. So she said, I'm going to let him put a PICC line in. I said, well, first question is, why are you putting a PICC line in? She said, well, that's in case we're going to have to admit you. So to get the poor young boy was shaking so bad, I told him, I said, you need to take a cup of Valium if you're this nervous.
You're a good patient.
he tried to get the vein. Of course, he missed it. And she wound up having to put the PICC line in. Then after that, the so-called doctor come to find out he was a nurse practitioner. He wasn't a doctor.
Mm-hmm.
And they took x-rays and they took sonogram, ultrasound rather, and his diagnosis was you got a hematoma. I said, a hematoma? I said, it's not blue. I didn't hit it or nothing. It swelled up. Anyway, he gave me some medicine. It didn't work. Wound up having to go to my doctor to get it diagnosed, and they diagnosed it as cellulosis. So I wound up 2-3 weeks here. There's no telling what the hospital bill is going to be.
Yeah.
So when you go to the emergency room, sometimes don't expect to see a doctor, and you liable to get somebody that's learning to work on you. So.
Yeah, Joe's right. I've talked about this for quite some period of time. More and more emergency rooms now are going to be staffed with nurse practitioners. Used to be they were dropping to physician assistants who are running these emergency rooms, but now even more quickly the nurse practitioners are coming in and they're running the emergency rooms, particularly in rural areas. That's what you're going to see. Remember we talked about staffing agencies? What you're going to find now are these staffing agencies that staff not only emergency department doctors, but emergency department nurses. And so they will, in order to bid for that service, they'll say, we will put a nurse practitioner in there who would charge maybe 60 cents on the dollar of what a medical doctor would charge, which would be maybe 80 cents on the dollar of what a physician assistant would charge. And that way they can keep the costs down so that the people get provided with emergency treatment. But it's not going to be treatment by a physician. And the people are going to have to decide, are we satisfied with care from nurses as opposed to medical doctors in the emergency room?
I'm wondering what the doctors are doing. I've been to the doctor a couple times where it's the nurse practitioners, and by the way, I find them to be very professional and good, and very great bedside manner, and we can talk, and if they didn't tell me and they just came out, I wouldn't have known it wasn't the doctor if it's my first time going someplace with a specialist. But I meet with the doctor once, and then there's x-rays done or CT scan, and then I never see that doctor again. It's all the nurse practitioner. Well, if there's a question on the x-ray, we'll run it by him, okay, or something like that. And, I mean, as a patient paying for these visits, I mean, should you ask to see the doctor? I mean, if I had any problems, I would say, yeah, you know what, I love the nurse here, okay, but I want to see the doctor because I want to ask him some hard questions about why I'm still not feeling better.
Well, but what if the hospital doesn't have a doctor in the emergency room? See what I mean?
Yeah.
That's what I'm talking about. There are going to be situations where that occurs, and you just have to decide where you go is going to be dependent on what type of healthcare provider you're going to see. Because like you, I would want to see a medical doctor, particularly if I had chest pain and I was concerned maybe I was having a heart attack or some type of anginal issue. I'm not leaving that emergency room without having a doctor see me. In fact, I'm probably not going to leave the hospital until I've got some arrangement to see a cardiologist as soon as possible. But the point is, you were asking earlier why there aren't more doctors. I think you're going to see fewer and fewer doctors going into emergency room medicine because they can't make enough money doing it.
Really?
Yeah.
You make more money in private practice.
Well, you're competing with nurse practitioners who can charge 60 cents on the dollar versus what you charge.
Oh, and so the hospitals are phasing out the doctors.
Yes, downward pressure.
Okay,
Anytime you got somebody else who can do your job for less, okay, that's going to drive down your wages.
Yeah, but I mean, the truth, talk about the educational difference between a doctor and a nurse practitioner.
Well, nurse practitioner goes to college.
Okay, 4 years.
4
right?
years. They get a nursing degree, and then they go to practitioner school, which is, however many months that is to go to practitioner school. Boom, you're a nurse practitioner.
A doctor. Most doctors.
4 years college, 4 years medical school, then there's residency, 2 years, 3 years, however long that is.
There's a reason you want a doctor. I have no bias against nurse practitioners who I've said are good, but they don't have near the training that a doctor does, and that's why there has to be a supervising doctor in an emergency room, because there's things that are outside the realm of possibility for a nurse practitioner to handle,
You're
right?
exactly right. They're supervising, but they're not seeing you.
Okay.
But you're exactly right. They supervise. They have to look at the charts within 24 hours of every patient that a nurse sees. So technically, you're right. There is a supervision element there, but that doctor's not seeing any patients. He's just signing charts.
All right, we'll take a break on that note. When we come back, man, I learned stuff from you that sometimes I wish I wasn't learning. No, but I'm glad.
You just need to know. Everybody needs to know what we're dealing with.
You need to know that stuff. All right, when we come back, we've got Pam and some other calls for you. Our final segment with Clint. Your chance to get in now. A lot of times, folks just getting up there, getting their coffee. Now they're ready to dial. Give us a call. We'll talk with Clint right after this.